So, welcome to another one of our Fujifilm video series. This is the retroflexion view with a cap using a 760Z gastroscope of the gastroesophageal junction of a patient who's had a POEM procedure before. There is good resolution of the dysphagic component of the disease, but as you can see, the gastroesophageal junction is wide open, and you can also appreciate from here that she has, despite maximum PPI, erosive esophagitis. And it is better, but she is still symptomatic from it, so we have to have a solution for that. And one of the solutions you can apply is an ARMA procedure or an anti-reflux mucosal ablation. So how do you do that procedure? Well, you do it in the classical way, following the method of Inouye with APC. We have APC forced flow 0.8 70 watts on an ERBI generator. We have an APC catheter down the scope here, which I'll show you. And we already prepared by making sure that everything was clean. So anatomy is important. If we just push back, you have the greater curved side and you have the lesser curved side. So I'll use my catheter to point. This is the greater curved side and this is the lesser curved side. You want your mucosal ablation to be about 1 centimeter from the esophageal mucosa. So from the tip off here, 1 centimeter down to the stomach. So we're not ablating on the reflux. And actually for a long time that was the thing that I worried about in these procedures, but actually I think that's good. And the other thing that you want is for it to be wider, your ablation zone, on the greater curved side than on the lesser curved side, and you want to leave a gap so that you have about 80%. So this zone where the scope is now should not be ablated. No. Finally, and probably also quite importantly, you need to select the patients correctly for this procedure. This is borderline, I think. And of course, I said to the patient, maybe this makes an impact, maybe it doesn't. But of course, in patients who've had POEM, you want to avoid, if you can, doing surgery, because those patients then get their achalasia symptoms back. So, let's go ahead. You can provide some commentary, PTM, when we're starting.
Yeah.
So we are going to start probably over here, and we're going to measure our 1 centimeter back, and we're going to start, and we're going to use in retroflexion. So I think it's actually a good way. You can either push the scope in like this, or you can drag the catheter back along the mucosa like this. Let's see which one is more successful. I do prefer the full control method.
Do you think you are far enough out of the scope now to...
I do. No, I think this is, I don't really think it matters. One thing you shouldn't be is this far out, right?
No.
I think this far out, it's too difficult to control what you're doing. You don't want it to be here because tip of scope is getting damaged, but yeah, this for me is a good distance. Okay.
You're probably more stable in retro than you would be in anterior view.
Yeah, that's, I think, absolutely right. So let's just try and define the length of our, or the width, if you like, of our potential mucosal ablation. We shouldn't be touching a little bit too much here. Okay, so we are probably about 1 centimeter, maybe a bit less from the junction. And this probably is a kind of width that we want to end up with. And then I'm just going to repeat that around the zone. Drag the catheter back. Of course, patients are not going to tolerate this when they haven't got an intubation because
gas formation.
Yeah, exactly.
With the cases you have already had, do patients experience pain after?
Yeah, they can.
So simple analgesics should suffice.
Yeah, right, but not. They're not getting severe symptoms. I think they're usually going home the day after. So we can compare that technique with this one, which is putting the catheter back. I do find that you end up getting a lot more amalgam from that. Let's have a look what we have. So we have a zone which is not onto the esophageal squamous mucosa, which is a little bit away, which is maybe a couple of centimeters long. And repeat, right? I mean, I think just make sure your position, make sure we're not too far away because it's going to have no effect, but obviously we don't want to be too close to the esophageal mucosa. Connect it to your previous. Keep going. Maybe the next thing we do is define the limits of where we're going to go to.
Yep. And also, if this does not work, or it works but not fully, this is something that you can repeat if needed. Probably
I've never done
not
it.
in this ideal patient, but
I've never done it. That's a good question. Can you clean, please? So let's just, while we're doing that, have a look and see. So this is perfect. We're not so close to the junction, so I think that's good. We need to take the gas out, and then let's define our 80% position. So probably de volgende patiënt mag al gebeld worden, Karen. Mag al komen. And then, yeah, so probably right here maybe. It can be mark number 1. We just be careful not to go onto the mucosa here because we're right there with it. So let's come down here a little bit. And then the other one maybe around here somewhere. So I won't go any further than that. We can start to define this, but this will be less wide than the other part. I wonder if you could do this with snare tip soft calculation.
I was wondering the exact same thing before we started.
I'm just not sure it would be so easy to paint it like this. I mean, it's just not. Yeah, it would take. I think it would take a long time. Would you get this sort of painting effect? I'm not certain. I don't know what you think.
Yeah, I think that would be the most difficult. Is the probably would be able to get the same effect as scarring. But
Yeah. You just also have to be careful a bit of the amalgam, I think, to do this precisely, because if you've got amalgam and you're not sure, it's the same with APC in all locations, right? Clean the catheter regularly. Yeah, maybe we clean. And also wash off so that you can see what you've done and what you haven't done here. We are relatively still all right, distance away, but we could just bear that in mind that we're getting close there. So I think, again, stay off it a bit and come down. But if we have a clean catheter, then we're going to be able to do painting, whereas if we don't, then we're not. And I think it's fine to go this way as long as you're not dragging, you know? So the dragging effect should not be done by pushing in like this. But I'm not
the
dragging.
risk of injecting.
Yeah, I think
or
you risk of
submucosa.
injecting ARMA into the submucosa, and then
Who knows what happens?
well, what happens is the patient gets significant pain and you can risk perforation. The risk, I think, of procedures like this, you're thinking that it's super easy and taking the quality control out of it. It's a bit like cold snare polypectomy, I find. You know what I mean? Like people view it as, oh yeah, it's just a bit of APC. Don't think about it. Just do it and end up with a problem. But I mean, I think we have to talk about results. I mean, the results presented, and we don't yet have enough patients to have a look at our data, I think, but presented results for this, for something which is relatively benign to do, and relatively simple. I mean, you have to say that it's relatively simple to do. We're getting quite onto the thing here, so.
I think as for everything, if you are meticulous on, if you think about it and you keep to your distances, then this is relatively simple. But if you start just doing it randomly, then
Probably right. So we can start to be narrower there as well, I think. So we're going to go like 1 centimeter type thing here. Maybe, let's check, but I think it's a good point. We no longer have reliable exit of argon, so you can slowly take.
in the meanwhile clean the mucosa.
Yeah, I think, and also take some gas out. It's very hard to see with the gas in. It's not a beautiful thing to do. I think a lot of us is in this because we would like to do things a bit creatively and a bit, this is just not something like that, right? Something a bit more akin to, RFA, or, of course, more difficult than RFA because it's not so standardized. Know thyself, PTM Portmans. Know thyself. I know myself. Okay, that is that then, I think. And to be honest, probably that is all right. Come around here, all the way around here. Maybe this little bridge here. And then we need to deal with the other side. So this is not complete yet.
Yep.
Well, we're nearly there, I think. Clean again, please. We'll clean it up and see what we've got.
And is it something that you would endoscopically check after a couple of weeks, the healing?
Well, I think for the post-POEM patients, I am checking their mucosal healing, to be honest. And so for her, we still don't have mucosal reflux mucosal healing here. So, I mean, if her symptoms go away, I think we could leave it quite a bit. But if she's still got symptoms, we're duty bound to check, aren't we, to see the effect and then to see what the next step of therapy would be if. So we've got a rim here of, about 1 centimeter, I would say. We're definitely not on this reflux, which I think is critical. And then we got because that is greater curve down there. So, sorry, that is greater curve down there. So the lesser curved part, is the part which is full. And then the greater curve part is not. I think you can see why as well, because it would make a little difference, right? And you don't want a stenosis, so I think it's a solid idea, that. So let's expand and just have a look. Yeah, we do, yeah. I'm not routinely giving antibiotics for this. No. So what do you think? Do we think that that's complete? Well, I think we've got enough of a gap here. Have we done enough at this edge? Maybe not down here a little bit more. It seems pretty uniform. Maybe there's a little gap there. So let's take this and just do some touching up. But yeah. Any other comments or questions from the room?
How do we know the extent if 1 centimeter is also the esophageal mucosa, but how do we know the extent that we should do the anything
So the question was, how do we know the extent of how much we should do the APC? Well, I think it's like a couple of centimeters here. So this length should be 2 centimeters, right? This length here, 1 centimeter, and here less. So here on this on the greater curve side, maybe it's 1 centimeter. Other questions?
So why do you avoid the
Why do we avoid what?
Why do we avoid the fun?
That's the, I don't know. We need to ask that to Anui. That is how he devised the procedure. I mean, I presume you don't want to do a full circumferential thing, because if you do, you're going to get a serious stenosis. But also, it does make anatomical sense, right? Because that there probably isn't going to come together, is it? That on the left side there. Okay, so I think we're nearly finished. Let's just check again. We have not got big gaps. I don't think we do. One more clean, please. Other comments or questions? Pitiana asked that before. Do we have pain afterwards? I mean, here's a little bit of an area which might need a bit more, I think, can have revealed by washing. Not so much. I mean, obviously they can do. It depends if you are putting APC into the wall, then I think they can. So we have some areas which are not fully treated, which we can now fix, and then I think we can finish. That was also something Pitiana asked. So I understand completely. Do we do relook? Well, we answered that, I think. Relook, we do. We do relook if the patient still has symptoms. I think you don't necessarily, hold please, have to relook if they don't. Okay.
Also one of my questions, and indeed, I know.
So the answer to the question, and what the question was, is it amenable to redo? I don't know the answer to that question, and I think we should investigate it. I also don't know of any studies which show whether it is or not, that have shown about 2 procedures. Interesting research question, but maybe someone out there knows that there is some evidence on that, and it'd be great to hear it.
That's indeed with the cleaning. You identified another piece that wasn't maybe fully treated.
Yeah. I mean, my fully treated, what is fully treated? Does it need to be black like this? No, I don't think so. It just needs to be, white. Okay. So we'll just have a look, we'll expand it up and check. I think, of course, less is more in this situation, isn't it? I mean, we have solved her problem with dysphagia. She has a minor reflux problem. Are we going to go really hardcore here? And I don't think so. check, and it's looking pretty good off the mucosa. So, all right. I think you should photo document in all these procedures. You should photo document what you're doing. Yeah. All right. Well, there you go. That was ARMA procedure, anti-reflux mucosal ablation with APC as per Inui. Thanks so much for watching.